So I think it's 12 o'clock now, Eastern Time, 10 o'clock Mountain Standard Time. And so I should introduce myself and we can proceed with this webinar. I must say that I'm delighted that the Brain Tumor Foundation of Canada invited me to do this, and that they have set it up and done all the logistics around it. Just as a brief introduction, I'm currently a professor and vice dean at the School of Public Health at the University of Alberta. I spent a large part of my career at the University of Illinois in Chicago, and in about 1989, the American Brain Tumor Association asked me if I would explore with them the feasibility of improving brain tumor data in the US. So I was involved in the early feasibility studies and development of the Central Brain Tumor Registry of the US. When I returned home in 2012 to Alberta, I expected to leave my brain tumor work behind, but the Brain Tumor Foundation realized I was in Alberta and asked me to do some feasibility work in Canada. So it's been a delight to be able to continue some of the work in this country. So my goal in this presentation is to give you a perspective on why we're focusing our attention on a brain tumor registry, and to give you a sense of the range of efforts required to reach our objective of improving care and improving outcomes in the Canadian population. My next slide. There we go. So I thought I would start out with some data that was available in from the International Agency for Research on Cancer in the 2000s. And they are the premier cancer surveillance group for global information, and they provide incidence and mortality and survival information by country. And the Canadian data on brain cancers or malignant brain tumors have been included in those reports for years. You can see that based on this report, the rates for Canada do appear to be high, similar to Australia, Brazil, and a few other places in Europe. And so it really does support trying to better understand what is behind these rates. But I also put up this slide to indicate that traditionally, this is what cancer registries have done. They have collected data on brain cancer and not on the full spectrum of primary brain tumors. Why do we have cancer registries? Well, their focus is on describing cancer burdens and trends and looking at distributions where cases may cluster, where there's disparities across different regions, so that questions can be asked and answered. The data is also used to design cancer programs, and once those programs are designed, it helps to evaluate how effective they've been, and the data are used to develop research hypotheses and studies from a range of things, looking at cancer causes, looking at cancer care, assessing quality of life. So brain tumors are a little different than most cancers. And so over time, a rationale for reporting all brain tumors has emerged. Schoenberg in the 1970s argued that malignant and non-malignant tumors are devastating, and therefore we need to be monitoring them, and that their prognosis depends on both the tumor type, the tumor location and behavior, and that there are unique patterns by tumor type and differing etiology by tumor type, and therefore we needed a mechanism to try to understand the patterns of these tumors. Nothing was really done, though, until the early 1990s, when the clinicians and basic scientists recognized the progression from low-grade to high-grade gliomas. And I think that this was the tipping factor in persuading the cancer registry community to make an exception and start collecting data on all primary brain tumors. You have to understand that in a cancer registry environment, brain tumors are 2% of their work. So they put a lot of time and effort into collecting high quality data on cancers. And this was a real shift for them. This chart is a simple demonstration of how a traditional registry reporting would include malignant cases and not malignant cases, but this was not meeting the clinical needs in the community. So when the Central Brain Tumor Registry in the US started, these were some of the first data that we were able to demonstrate. So you can see that the incidence rates almost double when you start incorporating the non-malignant brain tumors into a surveillance system. And we can expect this change to happen as the Canadian data on non-malignant tumors improves as well. So now we have really two brain tumor registries as models for us. CBTR is one of them, and they collect their data through the North American Cancer Registry System, and then they make that data available to CBTR analysts who work with the neuro-oncology stakeholders and clinical community to try to make that data as the most relevant possible. And it's been very successful. It's a well-recognized organization. Their definitions have been adopted by the International Agency for Research on Cancer for their data collection. So while their surveillance data supports research activity, it does not provide patients for research studies. The other example is brain tumor in the UK, where they're collecting all primary brain tumors plus secondary brain tumors. At the moment in Canada, we're focusing on primary tumors. We have not forgotten that the secondary tumors are important, and we will be looking for ways to address this in the future. So from a Canadian perspective, in the mid-2000s, the brain tumor numbers that were being generated by the Brain Tumor Foundation of Canada were estimated using CBTR rates because that was the best that could be done. The underlying assumption is then that the US rates and the Canadian rates are the same, and based on that map I just showed you, that assumption may not be valid. The other issue in Canada is that the number of cases by province is relatively small, which limits our ability to provide incidence rates and surveillance estimates and conduct research. And data on brain and other rare tumors are not reported on provincial public websites given confidentiality restraints. So it's hard to get provincial data outside of in a public format. So the only way to obtain detailed information is actually to combine data across provinces. I think it's fair to say that the experience of CBTR stimulated discussion in Canada. I know the Brain Tumor Foundation had a special committee looking at Canadian data, and that advocates spearheaded the work to get a private member's bill passed in 2007. It really is the passing of this bill that allowed our work to move forward with relative ease in 2012. Our efforts was supported by the Brain Tumor Foundation the background to this in the Canadian landscape was subsequently published, and we could make that available to you if you're interested. Following that, the Public Health Agency of Canada worked with the Cancer Registry System to look at what the barriers to benign brain tumor registration might be. And they had two major concerns that they published in an internal report. And that was that cancer registries did not have complete and accurate information on benign brain tumor cases, and that they may not be getting cases that were radiologically diagnosed. And so those are two concerns that we have taken to heart and are working on. Subsequent to that, Amanda Shaw at the Public Health Agency of Canada did an analysis of the 2006 to 2010 Canadian data. And really what she demonstrated was the information on malignant tumors is what we would expect in terms of numbers. Again, using CBTR as the comparison group. But in terms of non-malignant tumors, it's clear that there is substantial underreporting in the Canadian environment. She also showed that this underreporting of the non-malignant tumors varied across the provinces, suggesting that to address this gap would require different approaches in each province. And we also know that non-malignant tumors are less likely to be microscopically confirmed and more likely to be diagnosed clinically or by radiology. And traditionally, cancer registries have relied on pathology reports to capture cases. So what have we done since 2012? Well, first of all, we started exploring the existing data, so we had a good understanding of it with the funding from the Brain Tumor Foundation. We have published 2 survival rate manuscripts, and we have just estimated incidence rates by histology and subgroups, and that will be presented at CNO next week, but I will show you a little preview of that today. And then we got a grant to support a Canadian brain tumor registry from the Brain Tumor Foundation with matching funds from the Brain Tumor Foundation. And that really has allowed us to focus and move forward. And since then, we've been able to supplement that with a CIHR conference grant to look specifically at the issue around radiology. And we now have a CIHR grant to look at secondary data linking clinical and registry information so that we can begin to get information that is relevant to patient outcomes, a little more relevant. So this is an example of the first survival data that we estimated, and it includes 1992 to 2008. That's the entire time period that the Canadian Cancer Registry spans. And you can see, looking at this data, that from the histologies, that there is variation in survival rates across provinces. The red asterisks indicate there is a statistically significant difference between that province and Ontario, which was our comparison group, and these differences are most apparent for glioblastomas and diffuse astrocytomas. What does this mean? We don't really know, because the underlying data may not have been captured and coded similarly across the provinces over this time period, and that we know a lot of changes were taking place in classification. However, if it does reflect real survival differences, the next step would be to conduct in-depth analysis of tumor subtypes to see if this variation persists after controlling for all known prognostic factors. Because prognostic factors are not incorporated in cancer registries, we want to link to electronic medical records so that we can control for that in the future. This is a table that we generated realizing that we wanted to get a more current view of survival. But the most recent data that we could get through the CCR system in 2012 was 2008 data. So we made an effort to try and reflect more current diagnosis and treatment patterns. It should be noted, however, that big shifts in pathology and molecular diagnosis of these tumors began in 2007. So these data really reflect the Canadian experience prior to that. And so we need more current data to understand the current survival experience. So I wanted to share with you another way to present survival information, that is a conditional survival rate. This information can be helpful to physicians and patients as they experience their survival journey. For example, a person with diffuse astrocytoma has a 26% probability of surviving 2 years. But at 12 months after diagnosis, they have a 40% probability of surviving another 2 years. So gains in conditional probability were less pronounced for diffuse astrocytoma, likely due to already higher survival rates in that tumor subtype. We only examined the age-related patterns in this analysis for these two more common tumors, because we didn't have the sample size to look at at all of the categories. And we can see that there are significant gains in both of them as time goes on through the survival experience. Dr. Emily Walker will be presenting data on brain cancer incidence in more detail at CNO next week. We requested and received an updated cancer registry file through Statistics Canada last fall, and these updated data to 2013 are the most recent data available to us currently, which points to one of the limitations of using this system for surveillance data. There's a substantial lag time between the last year of data available and now. I know they are working to shorten this interval. So as you can see, over this 5-year time period, 12,000 individuals were diagnosed with a primary brain tumor across the country. Slightly more cases in males than in females. So this is a look at the incidence rates for selected brain tumor subtypes, and I really show it as an example of the kind of thing that we will be able to produce as we get all primary brain tumors into the data systems. So here you can see the incidence rates for glioblastomas is higher than for any other category of brain tumors, and it is more common in men than women. And we expect this picture to look much different once the non-malignant tumors are included, as meningioma has rates that are slightly higher than glioblastoma and higher in women than in men. Note that there is a fairly high rate of unclassified tumors, which is a data quality issue that we are working on. So I just wanted to point you to maps to give you a sense of the visual presentation we can make with some future surveillance data. These maps indicate that the highest incidence rate for kids and adolescents in Canada are in Saskatchewan, Ontario, and that for adults, they are in Quebec, Newfoundland, and Nova Scotia. We expect data patterns like this will lead us to ask questions about why the differences exist, and they may stimulate epidemiological investigations into the causes of these tumors. I do want to note that the Northwest Territories information is very unstable, and at this point we think unreliable. And we have started to make an effort to compare Canadian data to US data, and it points us to an increased ability to compare rates geographically. So right now we feel fairly confident in this comparison for all brain cancer. However, we expect some underlying misclassification within histologic specific tumors that may arise from a lack of detailed coding manuals being used in the system and a lack of focused training on brain cancer coding by staff at the provincial levels. And it also could be due to the transition that brain tumor classification has been going through since 2007, being applied differentially across provinces. However, these data are the best data that we currently have on malignant tumors, and they do seem to suggest a north-south gradient, similar to that we saw in the first IARC map. They also suggest there may be some north-south patterns in the east and west regions of both countries. Again, patterns which raise questions we can work to answer in the future. So what are some of our initiatives? Well, one of our initiatives has been to have consistent data across all collaborating provinces. And Ontario started their compilation on non-malignant brain tumors in 2010. So we decided to have Alberta and BC both make an effort to retrospectively identify non-malignant cases in their registries. That work is done now, and all new data were submitted to Statistics Canada in March 2018. So we expect up to 2016 incidence data to be available in the CCR next spring for all primary brain tumors, malignant and non-malignant. And I should mention that Manitoba has been collecting data on non-malignant tumors for years. And so our first report will include the 4 provinces, BC, Alberta, Manitoba, and Ontario. And we are working, Quebec started to incorporate non-malignant data about 2011, and we are working with them to explore the feasibility of incorporating Quebec data into this information as soon as possible. So through our experience of working with the data, we've identified 3 options for moving a Canadian brain tumor registry forward. I just wanted to share with you those options to give you a sense of what's involved in providing this data. I know all the data are electronic, and we have this idea that you can just, if the data are there, you can push a button and you can get it out. So I thought I would just give you some sense of the complexities that we're working with. So how do we get access to population data? When I first returned to Alberta, I was exploring cancer data resources. I discovered that Canadian Cancer Registry public data files had been released to what are called research data centers, and they are supported by Statistics Canada. This seemed like a good place to get familiar with brain cancer data, and so I decided to start providing baseline survival information that was not previously available in Canada. So we applied for and received a data file which included death information, which we incorporated into the 2 publications I mentioned to you. Surprisingly though, all cancer survival information was withdrawn from RDC users in about 2015, as Statistics Canada wanted to improve the quality of this information before it was being used any further. We received an updated file with survival information included in it this spring, and we were working hard to get a new more current report out, but Statistics Canada has just told us they would not allow this data out until further notice. So I think that reflects the care that cancer registries and data systems put into ensuring their data are accurate. But I also tell you this to highlight that while the data seem to be readily available, the reality is not always so easy. So in terms of the process of getting data, first you need human subjects approval, then you need a Statistics Canada review and approval. Then each person who's going to be handling and reviewing the data requires a formal application, security clearance, training, and oversight. And then the analysis is actually conducted in an RDC laboratory, which means that staff do not have access to the internet or email, so we can't communicate back and forth if they have questions until they leave the laboratory. So, and once the staff have done the analysis, no data leaves until there's review and approval by a Statistics Canada employee. So that really is a way of ensuring the data are secure, that there's some oversight as to the use of the data on Statistics Canada's part. The advantages of using the research data centers is the data are readily available at no cost, and we get routine updates of the data files. The disadvantages, and that there are strict rounding and vetting procedures which we need to follow using that data. So in order to provide our first surveillance report, we decided to go directly to provincial cancer registries. What that means is we will have to process, or we've just received actually, U of A ethics approval to move forward with a surveillance report. Each province now must get ethics approval on their own. And then once we have those all in place, we'll create data agreements with each province. Once those data agreements in place, will be put in a queue for provincial data file creation. And once the data is created, the data will be sent to us, where we will be able to create a file with all the provinces included in it to generate the tables that we want to incorporate in a report. The advantages of doing this is there's more flexibility and we can resolve unexpected data issues directly with the province that the information has come from. The disadvantages are data agreements and transfers are time consuming, and that every time we want to get updated data, we have to go through the process again. So in the long run, we would like to create a data system that is fairly routine and sustainable. And so what we've been talking about with our PHAC collaborators is that the Public Health Agency of Canada will provide analysis of the Canadian Cancer Registry data under the Canadian Brain Tumour Registry guidance. So what that would look like is that all the provinces are collecting the data the same, coding it with high quality standards, and submitting that data to Statistics Canada. And then the Canadian Cancer Registry file is already available to PHAC, and it gets regularly updated, so that facilitates the whole process. And Public Health Agency of Canada already analyzes data for some other Canadian cancer reports, so they're very familiar and have analysts on staff who are expert at doing this. And Amanda Shaw from PHAC is collaborating with us and is interested in fulfilling this role. And so we are working towards that. But while it's, and we hope that the second report that we generate will be done through this mechanism. It's nice because I think it will be the most sustainable model at minimal cost to get the information out to the neuro-oncology community. And it would allow the Canadian Brain Tumour Registry staff to support other research priorities in the community. And we can't think of any disadvantages of going this direction. So we'll continue to work in that direction. So we do have a question about, is population data complete? We know from the work that was done by the Public Health Agency of Canada using the 2006 to 2010 data that the Canadian system was at that point capturing 33% of all the non-malignant tumors. And so the question at the time was, where are the other 67%? So in Alberta, we've done a careful review of the 2010 to 2015 data. And in the Cancer Registry, before we started working with the Alberta Cancer Registry to add data, they had 50% of the cases expected, of the non-malignant cases expected in the registry. So we went through an intensive review using other databases to identify the non-malignant tumors. And we identified there's a discharge abstract database that seems to be a really good resource for picking up any hospitalization with a code that's relevant to a brain tumor. So after going through that review and adding all those cases to the registry here in Alberta, we now have 76% of the cases expected. So our question now is, well, we've made an improvement, where are the other 24%? And that really brings us back to the question of, are there gaps in the pathways of information to the cancer registries, and is it possible that radiology diagnosis explain some of this gap? We've started a number of data improvement initiatives. First is that DADS review that we did 2010 forward, and we're doing it in both Alberta and BC. That data has now been compiled and will be integrated into the Canadian registry by spring of 2019. And the data collection will be routinely including DADS reviews going forward. Some registries, I think, already are using DADS reviews, but other registries may need to adopt this as they strive to increase their completeness of the non-malignant tumors. This experience has allowed us to work with cancer registrars to create data coding guidelines that are specific to brain tumors and specific to non-malignant brain tumors that I think will help increase the consistency with how the data are coded across the country. So we'll need to get these coding guidelines adopted and then work with training cancer registrars so they understand this complicated 2% of their workload. And we also want to expand our quality control studies to other provinces because we know that the provinces vary in how they approach their data collection. So moving to the question about, are we missing cases diagnosed through radiology? We just had a conference in Edmonton, I think a week ago, where we brought in some radiologists, radio-oncologists, clinical people, cancer registry people, and had a robust discussion around what the current status is of using radiology, CT, MRI scans to diagnose brain tumors, and what's the pathway once that diagnosis occurs. So we've come up with, summarizing that meeting, about 4 pathways that we see. Patients may, a tumor may be seen on an MRI or CT scan. That tumor may go, that referral may go to a neurosurgeon. They may have surgery. Once there's surgery, a pathology report is created, and pathology reports with any cancer diagnosis are systematically reported to a cancer registry. So that means that for that particular case, that data is going to be accurate. However, there's other situations where an individual may have repeat MRIs and CT scans. They may see something, they may want to look and see if it's growing, is it not growing, before they make a decision about surgery. So so no surgery will be triggered until there's some clinical presentation that indicates it. So this individual will get reported to the cancer registry once the surgery has triggered a pathology report. So what does that do to the data coming out of a cancer registry? Well, it suggests that there's an accurate incidence because the case will come in the year of the surgery, and sometimes patients can be watched with tumors can be watched for a substantial number of years before that surgery takes place. So an accurate incidence and survival rates will result from this reporting delay. We also have another situation with repeat MRIs and CT scans where you may have a brain tumor diagnosis which is malignant and goes to surgery and a pathology report is generated. But then they go back for a repeat MRI CT scan a year or 2 years later, and the diagnosis changes. That patient may go from a low grade to a high grade tumor. So the reporting to the cancer registry will only occur when a subsequent surgery confirms the new diagnosis. So in this situation, the level of accuracy that we get in a cancer registry is dependent on the rate of progression of the tumors. And we really need to explore more about what goes on in this situation. The last setting is the one we expected, I think, when we started, and that is someone has a MRI or a CT scan, a tumor is identified, but that it's treated medically and there's no surgery. So it's not reported to the cancer registry because there's nothing to trigger a report. So all of those cases will be missing in our current surveillance data. And as radiology has become more refined and improved over time, they're getting better at diagnosing these tumors and making decisions about which ones do need to go to surgery and which ones can be treated medically. And so this is an important area for us to be focusing on and seeing if we can resolve this gap in the data system. So the answer is yes, we are probably missing cases diagnosed through radiology, and we are working to focus on solutions to that. So what are the immediate goals of the Canadian Brain Tumor Registry? Well, one is to enhance current surveillance systems, share what we are learning about quality case ascertainment and coding with all the provinces, and to complete this first Canadian surveillance report on all primary brain tumors that we're in the process of accessing data, and then to create a sustainable model for periodic surveillance reporting that includes all provinces, not just the 4 provinces that we're currently able to report on. We also want to facilitate research. And so one of the things we're doing is exploring the systematic collection of molecular data. As you may know, a new brain tumor classification system has just come out in the last year or so, which really incorporates pathology and molecular information in the classification of the tumors. CBTR has made some data recommendations around this, and we are in one of our quality control studies is currently evaluating the availability of molecular data on electronic medical records in the Alberta context, and we'll be exploring it in other contexts. We also want to demonstrate the feasibility of using cancer registries to address clinical questions in a timely fashion. We have a demonstration project that that's all approved. We're just waiting for the data to arrive, and it's a project that's been spearheaded between JESA and in Manitoba. Blanking on the name, I apologize. And this is really an interesting project because in Manitoba, they use PCV as a standard treatment for low-grade gliomas, and in Alberta, they use temozolomide as a standard treatment for low-grade gliomas. This isn't a randomized clinical trial, it's just an observational study, but because we have some difference in clinical practice in both provinces, it will allow us to look at the intermediate endpoints and some of the side effects of patients on these 2 treatments to see whether they're the same or different, and this will help in the immediate clinical decision making. Right now there is a clinical trial going on comparing these 2 regimens. That clinical trial, we don't expect the results for another 8 to 10 years because of the small number of low-grade gliomas that occur. So this kind of information will help physicians while they're waiting for the definitive clinical trial answer. So taking this experience with the demonstration project one step further, we wanted to demonstrate the feasibility of using multiple provincial registries to support clinical research, because one of the questions that's been raised in the demonstration project by the ethics boards and the funders are, do we have large enough numbers to really have a definitive answer? And so 2 small provinces aren't enough, and so we have engaged collaborators from BC, Alberta, Saskatchewan, Manitoba, Ontario, Quebec, to work with us on the feasibility of supporting clinical research, and we have a CHR grant application that's pending. And we also want to figure, because we have learned how difficult it is to get ethics approval and data access across provinces, we want to figure out ways to facilitate data access for other brain tumor researchers so that the researchers aren't spending all their time getting the data, but that we can streamline that in some fashion for the neuro-oncology community. So at the end of the day, what do we hope to learn from a Canadian brain tumor registry? Well, we want to know if all Canadian patients are receiving optimal treatment and achieving optimal survival outcomes regardless of gender, age, location. We also want to know if we have appropriate clinical services acceptable to all patients across the country. And we want to know if the number of people affected by brain tumors is changing, and if so, why? And that may stimulate further epidemiologic research on the question. So with that, I think I'd like to close my remarks. I'm looking forward to having some questions from the audience. And so please communicate those questions, and they'll get communicated to me. I'm not able to see the questions on my system, unfortunately. Oh, just to clarify the demonstration project, it's JESA and Marshall Pitts who are taking the lead on that clinical outcomes study. And while you're crafting your questions, I really should acknowledge the incredible support that has been given to this project through the Canadian Brain Tumor Foundation. They had the vision before I arrived, and they have supported the work since I've become involved. And to the brain tumor patients and their families for encouraging this initiative, and certainly to Brain Canada for funding the large grant, which is allowing us to really do a much more in-depth dive into the data and figuring out the most effective way to go forward, and to the Canadian Institutes for Health Research for the supplementary funding that we have gotten to address questions that have arisen in this process. So I would encourage those of you who are going to have the privilege of going to the Canadian Neuro-Oncology meetings to join us for a panel around definitions and classification of brain tumors on the Saturday morning, and to hear Dr. Walker present the incidence data that we have recently generated. Can I tell you about some of the biggest challenges? Well, I feel that the situation in Canada is in many ways, much easier than it was when we worked to develop the U.S. registry, and that's because the rationale for adding the all primary brain tumors to a cancer registry has really been well accepted and adopted through the CBTR experience. So in Canada, the challenge really is the data access across the provinces, because these are rare tumors. And so you can't really learn a lot about patterns of rates and outcomes if you just look at provincial data. Now, I know Ontario may be able to do a little better, and Quebec may be able to do a little better because they're large, but even then, when you get beyond the more common groupings of glioblastomas and meningiomas, they run into small data problems. So, so that I think has been the biggest challenge, is to just figure out the systems and mechanisms. Certainly the cancer registries have been very open to collaborating with us and supportive of the work, because it's just, they have a lot of work on their plates and they don't have time to focus on brain necessarily. And of course, the private members bill did not have any funding attached to it. So it's been a delight to work with in Canada, where the system is ready for this change. How much longer do we anticipate before a publication of these statistics are available? Well, the 2 survival manuscripts have been published. I did reference them on the slides that I showed you, and I would be happy to provide them after this talk. And then there's another publication out that just talks about the status of brain tumor reporting in Canada, and provides the rationale for it. We are working very hard on publications. So the incidence data will come out in publication format as fast as we can make it happen. The talk this week has all of the data that will be included in a publication in it. And so we are working on that now. And of course, we cannot, the timetable for publication is really in the publisher's hands, not in our hands. The incidence data will be done overall by histology subgroups, by age and gender and by province. How can others help and support? Well, I think that encouraging the use of brain tumor data within your own province is important, because I think the provincial registries need to know that there's a need for their province to have high quality data on brain tumors. So I think that's one way. If you're in the healthcare system, you can support encouraging clinicians to conduct research. We're happy to work with people who may want to learn from us this process of data access. And of course, the funding initiative that the Brain Tumor Foundation has going forward is supporting our current work, but they're already planning ahead for the kind of support that's going to be needed to keep a small team together who are knowledgeable and can support this work going forward. So I think cancer registries really respond when they see the data being used, and they take a lot of pride in the quality of the data and the completeness of the data. And so I think that it's important that that every province feels that it's important for their data to be used. One of the things I regret at the moment is that we haven't included the eastern provinces in this, and that Saskatchewan, although they wanted to collaborate, couldn't get approval from the Saskatchewan government when we started this project. So, you know, I do regret that we don't have all the provinces working with us at the moment, but we certainly hope to extend our hand to all of the provinces and work through the Canadian Council for Cancer Registries to just provide the background information and coding and definitional information to them that we have generated in this effort. Thank you. I really appreciate that you've taken time out of your busy schedules to learn more about a Canadian Brain Tumor Registry. And I know sometimes it's not as exciting as new clinical trials and new therapies being introduced. I consider it shoe leather epidemiology, and I think it provides a foundation for all of that work going forward. Thank you.
Thank you very much, Faith. I don't know if you can hear us.